Alright everybody, so this is going to be a video on the SI joint. Now there's a lot of information in this video, so I'm going to be putting up the abstracts of each study that I go over briefly. But if you're interested in reading more about it, I'll put the links in the description, just in case you want to read some more about it yourself. So the SI joint has been a point of contention and confusion among many people, and the understanding of the function of the joint has changed so much over the past 200 years or so. But with more evidence coming out, it's important we stay current with the information so we don't continue to spread outdated information. This way we can stay focused on treating in an informed way that's backed by science. So, again, this is going to be a lot of information, so I'll be doing brief summaries and I'll be putting up the abstracts of each bit of evidence that I have. But again, it'll be in the description if you want to read more about it yourself. So, starting off, priests in 2008 took 30 cadaverous pelvises and stabilized them. They looked at bony landmarks, such as the anterior superior iliac spine, abbreviated the ASIS. They looked at them bilaterally, and they found that there was differences among each pelvis by anywhere from 0 to 23 degrees, on average 13 degrees across different people. So it shows that it's normal to have different angles from person to person. But even more interestingly, they found that side-to-side differences on the same pelvis were around 11 degrees or 16 millimeters on average. Some studies Some studies measure in degrees, some studies measure in millimeters. But either way, it just shows that it's normal to be asymmetrical on the same person, even in asymptomatic individuals. And if this was an even bigger study across more than 30 cadaverous pelvises, it's likely there would be an even bigger difference in a larger sample size. So moving on from here, we're going down to Kibsgaard in 2014. They performed a radiostereometric analysis, which is just a type of medical imaging, that showed that in a single leg stance, there was only 0.5 degrees of rotation and 0 translation. So they concluded that the movement of the single leg stance is small and almost undetectable even by medical imaging. So we'll learn more about how small the movement is and how that can be a problem with diagnosis in clinic, because there are some orthopedic tests that completely rely on palpation to diagnose SI joint pathologies. But even with medical imaging, it's almost undetectable. It's very unreliable just to use palpation. So, moving on from that, we have Kibsgaard again, but in 2017, they looked at the active straight leg raise test for SI joint pathology, and they found that only 0.8 degrees of backwards rotation and a tilt of 0.3 degrees in the rested side was present. There was actually no movement in the active leg being raised. So that calls into question the entirety of that specific test. But in addition to that, you can start to look at other tests that just rely on single joint movements to diagnose pathologies in the SI joint. And a lot of them, especially if this test doesn't show any movement in the active leg being raised, you should really start to question some of the pathologies that get diagnosed from palpation. They concluded that the previous thoughts of rotation in the lifted leg were wrong. Now, going from there, Hestbick, and I may have pronounced that wrong, but in 2000, did a literature review of certain adjustment techniques used on SI joints. So, the detection of manipulative lesion in the lumbosacral area depends on valid and reliable tests, but we don't have any, and so it remains hypothetical. So this is going back to those two studies that we talked about before, where a lot of these diagnoses are coming from palpation and movement tests, but we don't have any reliable ones. So how can we fix something that we don't really know exists? Now, at Hanneline in 2009, they found that spinal and pelvic palpation reliability was very low, as we talked about, across subjects palpating. There was very low levels of agreement across the people palpating the individual subjects. But what they did find is that pain provocation tests have a very good reliability for the SI joint area. So subjective reports are incredibly helpful. So what this means in a clinical sense is that if we can't use motion or palpation tests to really determine anything, then pain provocation tests, where they actually have good reliability, maybe we should be looking at those more so than anything else when it comes to the SI joint area. Stovall in 2010 mentioned that similar to the palpation reliability not being great, it shouldn't be used as a main testing method for the SI joint pathology. So this is just building on to the previous information that we brought up. Thalberg in 1998 adjusted SI joints across a population who were confirmed to have an SI joint pathology, and then used another type of imaging called stereophotogrammetric analysis before and after. What they found was that there was zero change in joint movement or placement after the adjustments, but people did report a relief of pain. So we're not seeing anything change physically, but maybe the relief is a phenomenon from a neurophysiological standpoint. So one way of thinking of this is like, imagine having a pebble stuck in your sock when you're walking around. It's small, there's no damage, but it's annoying and potentially painful, and it can change the way you walk. So same kind of thing with, it could be said for the SI joint. You know, there's zero change in actual tissue damage or, you know, movement, but it is painful. So in the same way that the pebble in your shoe would change the way you walk, that pain in your SI joint will probably change the way that you move your lower back and pelvis. Now this is supported when we look at the large neural innervations for the SI joint area. There's lots of neural input in that area, so maybe it's just nervous, but we'll talk more about that in a bit. So Laslett in 2008 found that there are no differences in motion between asymptomatic and symptomatic sides in a symptomatic population. So they took people who were confirmed to have SI joint pathologies, and they measured the difference in movement between asymptomatic and symptomatic sides, and there was no difference in motion. He also found in the same study in 2008 that SI joint pain and discogenic pain rarely coexist. So again, this goes back to more of a neurological standpoint. If you get pain around the SI joint area, it could be disc or it could be SI joint pathology or pain pathology. So it's important to make those distinctions because those symptoms can actually overlap. One of the main problems with the pain provocation tests is that there is likely going to be a high degree of false positives due to the sensitivity around the area. So sometimes pain provocation tests can be unreliable, but in saying that, it does seem more it does seem more efficient than testing the aberrant motion of the SI joint because it's unreliable, especially even with imaging. So if imaging, when you're actually looking inside the joint and seeing it move under motion, if that's hard to detect even by looking at it, then palpating over skin blindly is not really going to do too much. So what do we know about the SI joint itself with regards to its function and its, well, we had already talked about its motion, but its innervation and everything else. So we know the SI joint, one of the main functions, if not the main function, is to help dissipate and transfer forces across the body. It undergoes a lot of compressive and shear forces daily, and it's very strong due to the large amount of ligamentous stability. There are tons of ligaments, the very strong ones around the SI joint, but those ligaments are highly innervated with a large amount of proprioceptive neurons. And we think it's the L4 to S2 area that innervates the SI joint area. So if something's going wrong in the SI joint area, there's a massive amount of nociception coming from the lumbar and sacral plexuses. This could result in altered sensations, guarding, pain, etc. So Vleeming in 2012 had an incredibly in-depth review on the anatomy of the SI joint, and it is very long, but a brief summary is that our way of thinking about the SI joint has changed so much in the past 200 years. So why wouldn't it continue to change with emerging research? We used to think that there was normal motion between the segments of the pelvis, like the ilium and the sacrum, but that fell out of favor in the mid-20th century. Current research suggests that limited motion, 2 degrees or less, in all 3 planes of joint movement, or depending on what studies you read, 2 to 4 millimeters on average. So if that's the case, we can't really say that a dramatic leg length shift is due to the SI joint from such minute motion. Even doubling the average to from 2 to 4 millimeters to 4 to 8 millimeters wouldn't even cause anywhere close to an inch of difference. And not only that, our SI joint is incredibly durable. It's not fragile. So if someone's getting a lot of pain in through the area, how do we fix it? Well, for that, we can look to some promising new research studies on isometric exercise and the effects they have on exercise-induced hypoalgesia. So all that means is exercise-induced reductions in pain. So for our first study, we're looking at Rio from 2015, where they took 6 volleyball players and measured pain with a single leg squat, and then they compared the effects of isometrics and isotonics. So the difference between those two is isometrics are a contraction that's held for a long period of time with no range of motion, and isotonics are full range of motion exercises. So what they found was that isometrics, so holding the exercise in a contracted state, immediately caused pain reduction for 45 minutes, along with an increase in strength scores likely from decreased inhibition through the muscle tissue. Next, we can look at Hyung Sung from 2015, where he took low back pain individuals. They were divided into a control and then 2 types of isometric exercise. So the results were that after doing the protocol of 5 sets over 3 times a week, for 6 weeks, caused a decrease in pain and an increase in muscle activity around the area. Next, we have Van Ark from 2015 as well. So what they did in this study was that they took 29 athletes, they divided them into isotonics or isometric exercise for patellar tendinopathy. They used 4 exercises for each group and then scored them on the single leg squat after 4 weeks. And what they found was that there was no significant difference between the 2 groups for decreases in pain, but there was a tiny difference in favor of isometric exercise. So what this study is saying is that the decrease in pain can come from both types of exercise, but so far we've seen more evidence towards the isometric versions of them. Next, we'll go back to Rio, but this time in 2017. He looked at 20 jumping athletes with patellar tendinopathy. He divided them into isometric leg extensions or isotonic leg extensions. So again, isometrics are held for an amount of time and isotonics are full ranges of motion. What they did was they gave them exercise protocols 4 times a week for 4 weeks, and they measured it again by the single leg squat. Both groups had a decrease in pain, but in this study they found that isometrics have a much larger analgesic effect, so a much larger degree of exercise-induced reductions in pain. Next we have Soror from 2014, and what they did was they took 3 groups of osteoarthritic female patients, and they had 3 groups of 30 people, 1 a control, an acupressure one, and an isometric. So in this study they were measuring the difference in decreases of pain from acupressure versus isometric. Now they found both groups had a decrease in pain, but the isometrics also increased physical function. So what they recommended was a blend of both. So we can sum that up as they would recommend massage in conjunction with exercise to not only decrease in pain, but increase your physical function. Now we're moving on to Vaidgar from 2013. So in this study, they took 80 healthy subjects between the ages of 18 and 65 years old. They tested pressure pain thresholds before and after aerobic exercise plus isometrics. They found that high-intensity exercise increased the level of exercise-induced pain reduction, and it lasted afterwards. Next is Colton from 2013, where they took 16 people, and they did painful exercise, non-painful exercise, and then they had a control group. So those were the 3 groups. They measured actually heat pain after each session instead of just mechanical pain. They found the biggest decrease in pain came from actually painful exercise, but non-painful exercise still had a decrease in pain. So this just shows that exercise can have an effect on multiple types of nociceptors potentially. Instead of just mechanical, we saw that heat pain was reduced. And interestingly enough, it was from the painful exercise group. Now this is likely because we're biological beings, we can adapt to the stimulus that we get, and the larger the stimulus, the more of an adaptation we get. But I think when it comes to clinical relevance, it depends on the person. So are they willing to do that versus non-painful, because we saw a reduction in both. So one more study that I'll mention is Nagel from 2014, who demonstrated that pain catastrophizing, which is worrying about being fragile and broken, actually diminishes the effect we have on pain from physical interventions. So, for example, if you go to see some rehab professionals and they tell you that something's out of place, you need them to get better, you likely won't be able to get better on your own, and it'll be a long healing time. Those are all things that add to a negative mindset where you're not able you're not able to vision fixing yourself, and you envision yourself being damaged for long periods of time, worrying about that constantly, maybe losing sleep, all that stuff. All of that has an effect on chronic pain and psychosocial pain. And if you're unsure what I mean by that, it has to do with a term called nociception. So I can link a video that I did on that down below. But going forward with this video, basically, if you tell someone that their pelvis gets out of place with everyday basic activities, which we know can't really happen because it's such a strong and rigid joint, and the main function is to transfer force, you end up setting up someone for failure in the long and short term due to the fear that that induces in the person. So instead, think that you're anti-fragile. So again, we have resilient things, which are things that when they get broken, they can go back to the state they once were. We have fragile things, which is when something gets broken, it can't go back to what it was. And humans are anti-fragile. We know we can train ourselves, even when we're broken or hurt or anything like that we can get back to a state that is superior than what we once were. We can get stronger. So my opinion is that the evidence is pretty damning for the idea that adjusting an incredibly strong joint like the SI joint provides any sort of mechanical change. It doesn't seem like something that's needed anyway due to the heterogeneous nature of the SI joint, referring to the fact that asymmetry is normal, and even in asymptomatic populations. Instead, it seems more promising to focus on what we can actually change, which is resilience and mobility of the surrounding tissues, psychosocial factors, and as clinicians and rehab professionals, not providing any sort of nocebo effect by catastrophizing the pain in our clients and feeding into the narrative that people need to be fixed by our techniques. Instead, what we should do is we should use our pain-modifying techniques such as massage or adjustments, foam rolling, scraping, needling, whatever you want, as a way to help the client load the painful area in a pain-free or at least less painful way. This is the type of approach I like to take for most things, but it's simple to say, but it may not be easy. But it's also evidence-based and it's effective. Thanks for listening. Hope you enjoyed, and stay tuned for the next video. Bye.